So welcome everyone to Rayos contra Cancer and this discussion with Dr. Hiram Gay about contouring the GTV. Dr. Gay did his medical school at the University of Puerto Rico and did residency at SUNY Upstate New York and is currently a professor at Washington University in St. Louis, specializing in head and neck cancer. And with that, I will hand it over to him.
Okay, good morning, everybody de Latin America. So the topic of the lecture is contouring the GTV. So we are going to go through some cases. I want you to, feel free to interrupt me and ask questions. Our goal is to, build everybody's confidence into contouring head and neck, trying to simplify the process of contouring in head and neck and make it less intimidating. I know a lot of people find the whole process a little scary, but if you do it properly and with a good thought process, you're going to be able to help your patients, whether it's a curative patient or a palliative patient. So let's get to it. And I'm going to move the next slide. Disclosures, I just have some, project collaboration with Boston Scientific for prostate cancer, so it doesn't have to do anything with this, and it's mainly consulting, nothing for profit. These are helpful references from, my predecessor who had done the initial version of this talk. At your leisure at home, when you see it again, feel free to look for these references, download them. If you have any trouble finding them, that they're not free access, feel free to reach to any of us, and we'll get that PDF and send it to you. So for head and neck cancer, this is a search and destroy mission for the cancer. So you have three main helpers to help you find the cancer. Okay, imaging, it's incredibly powerful to help you define the anatomy of the patient, the three-dimensional geometry of the tumor. It's a huge help, and there's many tools in terms of imaging you can use. Second, in the definitive case, maybe to a lesser degree, the pathology. What type of tumor are we dealing with? And the pathology report usually should have a mention of where they got the biopsy. Did they get the biopsy from the epiglottis? Did they get the biopsy from the right vocal cord? Was it the left vocal cord? Was it the right buccal mucosa? So that gives you information anatomically of where the cancer was found. Was it a lymph node on the right side of the neck? Was it a lymph node on the left side of the neck? So that's very useful information to have. Of course, for patients who are surgical or post-surgical patients, which is not the focus of this talk, the focus of this talk will be mainly focusing on gross tumor definitive cases. The very thorough pathology report has a wealth of information that will help guide your planning, whether it's perineural invasion, positive margins, extracapsular extension of the lymph nodes, bone invasion. All these things will help you delineate your plan. And of course, the physical exam. Skin involvement, unless it's really advanced, it's very hard to see on imaging. Mucosal involvement, alveolar ridge involvement, palate involvement, even base of tongue invasion creeping from the tonsil. It's really hard sometimes to appreciate nuanced findings on the CAT scan, on the PET scan, and that's where your physical exam is very useful. So let's go to imaging first. We love to fuse data sets when we plan for our head and neck patients. At the bare minimum, I try to fuse an FDG PET. Prior to starting the treatment, I'll have my CT with contrast for simulation, and I may or may not fuse an MRI, but the MRI is rare. We rarely use it. I'll tell you some indications. But in low resource areas, if you just have a CT without contrast, it's very hard to find the GTV at times, and then you'll end up having very big margins to cover your target. The CT with contrast is very, very helpful for distinguishing between the blood vessels and the lymph nodes. And some tumors enhance very nicely, so you can tell what's normal tissue, where the tumor is. It's very useful. The PET CT, it's a luxury, we have, and it's incredibly powerful for delineating especially squamous tumors. But you have to be aware normal activity, etc., that it's not tumor and it can throw you off and you might want to treat something that's really not cancer. MRI has its utility. We don't use it as much for head and neck as we use it, for example, for prostate cancer, but for salivary gland tumors, for nasopharyngeal tumors, when there's like really obvious nerve involvement, the MRI can be very, very, very powerful as to help you delineate the tumor. And some facilities have an MRI combined with a PET scan. I think over the years I've used it a few times. And the nice thing is like the PET will be really properly aligned by default, with the MRI. Both will be like very good correlation. So for certain tumors, nasopharynx especially, that can be quite useful. We always have to think about time. When was that imaging done? Was it done days ago? Was it months ago? Was it weeks ago? You have to take into consideration that the tumor is constantly changing. So what the PET scan shows from 3 months ago may or may not apply completely now when you're treating your patient. Pay extra attention to your CT simulation because there could be new findings. The tumor might be larger, new lymph nodes could have grown. There could be inflammation or an infection that could throw you off in terms of what's going on. So always take into context the timing of the imaging. If there's a big delay between your simulation and starting the patient, things could have changed. Maybe you need to rescan the patient to see if anything has changed in terms of your targets. If the PET scan has some false positives, occasionally we'll see some brown fat. Salivary and lymphoid tissue can light up. The tonsils are notorious for that. Sometimes the patient is tense and the muscles will light up, but it's just normal physiologic activity. The patient could have had a biopsy that could enhance, a lymph node, for example. And false negatives, necrotic nodes won't light up. It's dead tissue inside there. There's a necrotic hypoxic, probably a more dangerous lymph node than the ones that light up, but it might not show up on the PET scan. Pathology, the biopsy report noting the location of the biopsy. Like I said before, a comprehensive surgical report is very powerful. That image I generated with AI, and it's interesting, the computer's interpretation of what a pathology report should look like. I don't know what that is, but it looks creepy. Physical exam, very powerful. Visual examination of the neck and oral cavity. Is there skin involvement? Is there cancer by the stoma that the patient has? Is there a fistula? Is there like a submandibular node that is having a fistula and drainage? Is the alveolar mucosa involved? Is the buccal mucosa involved? Is the epiglottis involved? Is the aryepiglottic fold or the piriform sinus? Some of these things may be difficult to appreciate on a CAT scan, on a PET scan, and the visual inspection is very powerful. Of course, the flexible nasopharyngoscopy is very powerful. Sometimes all you might have is a mirror laryngoscopy, and that's the best you can do, but any visual inspection can help you formulate in a very robust way where the targets are. All we're doing at the end of the day is where's the targets, and you want to make sure you don't miss the tumor targets. That is it. So visual examination, you can see some examples of a tumor in the oral tongue, the palate. alveolar ridge, etc. So it would be very hard for you to see these findings clearly on a CAT scan. The CAT scan will probably be read as normal, but from the visual inspection where this subtle abnormality is. To your eyes, it seems obvious, but on the CAT scan, it would be very difficult for a radiologist to pick this up. So great head and neck contouring is like growing a strong and healthy tree. What do I mean by that? So your GTV primary, that's the core, that's the most essential thing. The first and most essential thing you need to make sure you cover properly. If you don't cover your GTV primary properly, the whole plan is going to fall apart. The patient is going to have a recurrence. Second, very important part not to miss, the gross tumor in the lymph nodes. That is what makes the skeleton of your plan. Those are the areas that for sure there's cancer there. If you miss part of it, the cancer is going to recur and the patient is going to have a bad outcome. So without strong limbs in your tree, without a strong trunk, the whole plan falls apart. So you have to pay extra attention to make sure you have as good mapping of these structures as you can. Your CTV is like the canopy, like the leaves of the tree. They complement your plan. There may be cancer there. There may not be cancer there, but these are what finalizes the robustness of your plan. Still important, but the core, the mainstay is your trunk, your limbs, and the CTVs are like, it helps finalize your plan. You can think of your PTV as, putting your big, beautiful tree in a greenhouse. You're protecting everything, you're encapsulating everything, you're making sure you encompass everything. And that is the simplest visualization of what a good plan is. So keep it simple. For most head and neck treatments for gross disease, I use two doses, PTV 7000 for gross disease, PTV 5600 for elective nodal areas. You want a third dose level? Ask yourself, why do you want to do that? I think for nasopharynx, usually there's like, a lot of the protocols specify like 3 dose levels. And I think, mainly because of the location of critical structures, you have like this 3-leveled tier dosimetry, but, try to keep it simple. If you really believe in doing 3, 4, 5 dose levels, have a good rationale why you're doing it. Otherwise, you might be overcomplicating things and, spending more time than you need in your contouring. For gross disease, you would probably want to edit out air cavities, bone and muscle that is not involved. That will help you keep your structures more compact. Think strategically about the anatomy. If you're treating the lower lip, have the mouth open. You don't need to treat the upper lip. When you do your expansions, pay attention. Like, you're treating a lower lip, don't make your PTV so then you treat the upper lip. There's no reason to do that. The same thing if you have a tumor in the floor of mouth. When you do your expansion, if you're treating the soft or hard palate, ask yourself why. I mean, if there's soft or hard palate involvement, sure. But if there's no good reason that the tumor went all the way up there, pay attention to your expansion and, keep it tighter. Buccal mucosa, you could have a tumor on the buccal mucosa. You do your expansion. Don't get too much into the oral tongue. You might need to do some of that a little bit just for your uncertainty, but don't make a gigantic expansion into the oral tongue if there's no joining or continuity of the tumor there. So here's a CT, without contrast. So, now let's just do the interactive portion. So I want anybody who wants, we won't know who you are. You can do the annotate tool. and, draw, whatever you think, the tumor is in this slide. I mean, see if you can tell if there's a lymph node, if there's a tumor. There's no right or wrong answer, but I encourage you to try to do that. I guess it tells it said who it did it.
So,
but have a few
Yeah.
people, just for the fun of it, try to draw lymph nodes, tumor. I really don't know what it is. We'll find out, what the right thing is. So let's count, let's do 10 more seconds.
The annotate tool can be found in the lower left-hand part of your screen typically, but feel free to comment on the chat if you need. Yeah, I see his comment.
It's in
lower
the
left-hand
tool.
typically.
Is there, in my view, there's like a menu that pulls down and it'll say annotate. But I see a number of people have done it. Great. So no right or wrong answer. Let's go to the next slide. Keep drawing. And let me turn off my annotate thing. Okay, let me go back. Okay, so this is with contrast. So why don't we reset the image and let's have everybody try again when we have the contrast. Okay, perfect.
It's easier now.
There we go. Okay, so with the contrast, it seems like people feel more confident of where the tumor is. I can tell that there's better correlation there. So let's clean the screen for a second. So let's stop drawing. So that red one in the beginning, that was the contour, the way I drew it. I'm not saying it's right or wrong. This is my contour from that time. I saw a little lymph node there anterior to the sternocleidomastoid. This is a location that it's easy to miss the lymph nodes, because a lot of the atlases, we tend to think underneath the muscle and pay attention to a lot of that, but sometimes there's a little lymph node in front of the muscle that you don't want to miss. And then this is my CT, this is growing the tree, right? We have my GTVP for the primary, my GTVN for the lymph node, my CTV 7,000, which is encompassing the gross tumor volumes, then my PTV 7,000. So I did an asymmetric expansion in this case. So the lymph node I expanded by 5 millimeters. The primary I expanded by 1 centimeter. I put all that together and then I expanded by 0.5 centimeter. That's why you see the GTV primary expansion is bigger than the nodal expansion. And then here's my CTV 5600. And then my PTV 5600. So, and we're shaving it off like 3 millimeters from the skin. So this is what I'm talking about, growing a tree. The GTVs, that's kind of the trunk of the tree. And my CTVs are like the leaves of the tree. But if I don't do a good job with the GTV, if I miss it, I'm going to have a much higher chance of recurrence. And this is a PET CT. That's how it looked. So I would say that both the CT and the PET scan, were useful in this case. I think they correlated very well. Maybe if you didn't have a PET scan but had a CT with contrast, you would have done a really good job at delineating the tumor. But if you just based everything on the CT without contrast, it's very hard. It was very hard to tell what's going on. Okay, let's go back. Okay, so let's go to this case, see if you can tell where the tumor is. And I feel like it's not a fair question because I'm not giving you the clinical history. I'm not giving you a photo of where I think, but let's just try to think, where do people think there's something wrong? Okay. So let's go to the next slide. Let's just clean this slide. And this, we can stop drawing that now for a second. What I want to show you is the red circle is my GTVP, the primary, okay? That's the red circle. So this circle here, that's the primary. This is the lymph node right here. This is the normal muscle, so I didn't include it in this case, but it's very hard to tell from this image. But I want to show you the impact of expansion. So this is my tonsillar tumor. This is 0.5 centimeter expansion of the target, 1 centimeter expansion of the target, 1.5 centimeter expansion, and this is 2 centimeter expansion. So you can see that as you start expanding more and more and more, you're treating more and more of the oral cavity. At this point, you're eating into the bone, you're eating into the mandible. So usually what I would do if I have a good PET scan, if I have good tumor delineation, if I'm confident where the tumor is, for a tumor like this, I'll expand by 0.5 centimeter to get my CTV, and another 0.5 centimeter. And this is like Benjamin wanted me to point this out, the 50/50 rule. 0.5 cm expansion for the CTV, 0.5 cm expansion for the PTV. So, you know, I would end up in this line. Can we clean the screen again? So my PTV expansion would end up right here. And honestly, at this point, I don't have to edit much because I'm not even touching the mandible. I'm not touching the vertebral body, so it works perfectly. Like with no editing, I'm good to go. Sometimes I'll expand 1 centimeter, so I'll go to the orange line. And, you know, maybe here I start to need to edit just a little bit to pull it out of the bone or something like that. But I just wanted to show you, like, even a tiny, tiny tumor in the tonsil, you know, this is a little bit larger, but once you start doing incredible expansions, you start treating more and more normal structures. And that's why PET scan, exactly, we can get, you know, carve it out from the air, etc. So that's why the PET scan, like contrast, can help you narrow down your margins. If we just had a CT without contrast, I probably would end up having, you know, my target with the orange line, or, you know, getting closer to the yellow line, just because I don't know exactly where the tumor is. So this is the advantage of having good imaging and also a good, you know, physical examination. Okay, so let's clean the screen. We can go to the next slide. How about here? Anybody can see anything here? And by the way, in the corner of the screen, if you're watching from a cell phone, you won't be able to see, you know, I put a little story of, you know, the history of the patient. That's for you at home to check later. I just want you to ignore that and just do the best from looking at that. So this is a CT without contrast. Okay, great. And let's clean it. Let's clean the screen right now. And this is where the primary was in this case. So very tricky case. And how do I know this? You know, I just from looking at it, it's hard to tell. It's because, you know, I have the PET scan information here. I have the description of where the tumor is from the physical examination. That's how I can tell, you know, where to draw my GTV. Otherwise, without that context, it's very hard just from looking at the image to define where the abnormality is. When I look at an image, I want to look at symmetry. How's the right side different from the left side? Is there something on the right side that's different from the left side? Those are clues that there might be something there. And in this case, you see that the right side is fuller. There's something definitely there, but it's really hard to tell. The PET scan helps us quite a bit in this situation. And then this is my CTV expansion. Here's another case. This is a patient with P16 squamous cell carcinoma of the left tonsil and had extensive bilateral lymphadenopathy, participated in the keychain trial, received 70 gray. But let's see, it's left tonsil. So it would, so I see some drawings on the right, some drawings on the left. Let's see what happens. So let's clean the screen. And now this is showing the PET scan. See if, try drawing it again now that you have the information of the PET scan. And again, this is a left tonsil cancer. Okay, so let's clean the screen. Let's clean the screen. Great job. Let's clean it. We can, sorry, we can stop drawing. Let's just stop the drawing for a second. Okay, so those red contours, that's what I ended up drawing. So there's a little lymph node on the right side. My GTV on the left tonsil is that red circle, and then there's some lymph nodes on the left side. And the point I want to make with this slide is that uptake on the right side, you know, this thing over here, it's like that's normal tonsil uptake. There's no tumor there. You know, the tumor is here, it's enlarged, but it can be confusing. That's why like the PET scan can be very powerful. It can be very helpful, but you need to put everything together in terms of the physical exam, etc. It's often you'll see uptake here in the base of tongue, in the tonsil. It's normal. There's nothing to treat there. But because I know that the tumor is on the left side, because of the physical examination, etc., I know, you know, this is the correct GTV. Okay, let's go. Let's clean it. Let's go to another case. How about this one? This is a clinical T3 and 2, P16 positive of the right tonsil, and was in a vaccine protocol and got 70 gray and 56 gray. And again, we're drawing the GTV, the gross tumor. So no elective areas. All we want to do is like, you know, whatever you see grossly, do your best at drawing it. Okay, great. I feel like there's much more correlation in this case than in the other one. Let's clear the screen. Let's hold off from drawing. So if everybody can pause the drawing. So the reds, these reds popping up, those are mine. That's what I drew. So you can see the primary, you can see lymph nodes, and again, there's a little bit misregistration, but let's look at the PET scan. So the PET scan is showing, you know, where some of the lymph nodes are, where the primary is, but that left-sided base of tongue uptake that we see here, this thing here, that's normal. There's nothing, you know, cancerous about that. Our cancer is here, our lymph nodes are there. I could, if I drew it again, you know, I might draw it a little bit differently, but in essence, you know, I think a lot of people picked the primary and they picked the lymph node, so good job. Let's go to the next case. Let's clean the screen. How about this case? This is a patient with a T4 N2B P16 negative, poorly differentiated squamous cell carcinoma of the right base of tongue, extension to the right oropharyngeal wall, across the midline to the left base of tongue, and AE fold. So it's, you know, quite extensive superiorly, inferiorly. Couldn't have surgery, and we do a lot of surgery at WashU for better or worse, and couldn't even get chemo because of poor status. So great job. I see like a lot of people are in agreement. Let's clean the screen for a second. Let's just stop drawing. Let's just clean it. So the GTV primary is this red one I drew here. The green one is a lymph node. And this is, go ahead. Did somebody have a question?
Accident. It was an accident. You can continue.
Okay. So, you know, here you see, here the PET scan is super useful to help define these targets. Otherwise, this is a CT without contrast. The patient unfortunately couldn't have a contrast. You can see that it threw a lot of people off on the other side, etc., because it's very hard to tell what's a lymph node, what's a muscle. The PET scan really here saved the day in this situation. Very powerful tool to help us determine the target. How about this case? This is a P16 positive squamous cell carcinoma, unknown primary, left-sided cervical node metastases. Because of COVID, wasn't able to undergo surgery. So he was treated with definitive chemoradiotherapy, had 3 cycles of cisplatin, received 70 gray in 35 fractions. What a nightmare COVID was. Okay. I see some agreement there. Let's clear the screen. And so this is the lymph node. So understandably, some were thrown off. This is muscle. So this thing I'm drawing here, that was muscle. That's not a lymph node. You can see clearly the blood vessels here, blood vessels. These are muscles. These are muscles, so that's not lymph node. This is, what's drawn there is this big lymph node from the unknown primary. Let me see if by any chance this has a PET scan. No, this doesn't have a PET scan. Let's clean the screen. Let's go to another one. How about this one? This one is, I kind of gave it away. Okay, this one is tricky because this one, be my guest, whoever wants to take a crack at it, go for it. But this one is a very unfair case because it's very hard. I'm looking at it, and if I didn't prepare the lecture, I wouldn't have known what it is or what it isn't. But this is a T1B glottic squamous cell carcinoma. He actually had a tumor in the left true vocal cord. From the imaging, I can see a thing abnormal, really. It's, I see some people have, okay, let's clear it and let me draw. So I want to show you a few things. So, these things, that's normal blood vessels. Some of these things, might be, normal tissue, muscles, sternocleidomastoid. So in this case, what I did, I drew both the right and the left vocal cords just to make it symmetric. This is, the true target is here. It's in the left vocal cord where I'm drawing here. It's really impossible to tell. This is a true GTV, but since I want to treat the whole larynx, that's why I drew it like that. I'm drawing the anterior commissure here. And then, when I did the expansion, it looks really nice, all around it. In this case, there was some questionable lymph node, and that's why I ended up doing IMRT. Otherwise I could have done, like a parallel opposed simple field, like a square, but there were some questionable lymph nodes, so I ended up treating the neck, and that's why it's a little bit overcomplicated, but that's beside the point. Let's see if I can get rid of the annotation. There we go. Let's clean the screen. And, this is a tumor. I think in this case, they're looking from below. So this is the abnormality in the left vocal cord. You can see it here. So, without that information, if you don't look at it yourself, you really wouldn't know what to worry about, etc. So very important, your physical examination. Okay, I gave it away. I clicked too quick. But how about this one? This is a P16 positive squamous cell carcinoma, clinical T4, N2, M0, treated with 70 gray and 56 gray bilateral elective nodal regions, finished in 2022. I think the system is really cool to see, like, everybody contouring it. I love it. It's like I feel like AI is trying to, find the targets.
It's like a contouring workshop on steroids.
Yeah, it would be cool if we like all the contours were overlapped, so where there's more concordance, it's like red, and where there's less concordance, green, or some, like a heat map of where people agree or disagree the most. Okay, great. Let's clean the slide. And I'm gonna click this. These are the targets I drew. Sometimes there might be a little bit discrepancy just because sometimes there's a little misregistration between the PET and the CT, and I try to get the worst case scenario. But here you can see the primary on the PET scan. Again, some discrepancy with how correlated they were. We also have to take into consideration the time points, how things grew between one data set and the other. But, I do see a number of smaller lymph nodes. Sometimes it's hard to make that call unless you're scrolling up and down. Scrolling up and down can help you determine if it's a vessel or if it's a lymph node. Again, it looks like this patient didn't have the luxury of contrast, but between the PET scan and the CT, I try to be as comprehensive as possible, whatever looks suspicious in terms of my GTV. Okay, great. Let's go to the next slide. How about this one? This is a 72-year-old, female with a history of breast cancer. And then, unfortunately, she's the rare female with P16 positive cancer in the right tonsil. And it was including the medial pterygoid muscle, the uvula, the peripharyngeal space, vallecula. So very extensive cancer. Anybody had a question? There was also encasement of the carotid artery and right level 2 and level 3 lymph nodes. Okay, so let's clean it. And I want to highlight something here. Let's just stop drawing for a second. I mean, you can see like a necrotic node there. These are hypoxic. These are usually, sometimes I fear these necrotic nodes more than a full node. Let me get rid of the annotation. And let's clean. Okay, so the red is my primary tumor. The light blue is where I put my lymph node. You can see it. You can see the PET here. On the other side, it's probably some misregistration, neck, muscle activity, like at the tongue, tip of tongue, there's some activity there, but it's not tumor. But these were the targets for this particular case. How about this situation? So this is a little trickier. This is a 69-year-old woman with a T1 NX adenoid cystic carcinoma of the right submandibular gland. Had surgery and radiation at an outside hospital, and then she had a right-sided surgical bed recurrence. Okay, so this one, I think it's, challenging, and it's an unfair case, so let's clean it, because I want to show a few things here. This area, this is the left, so this is right. This is left. So this is the left parotid gland. That's totally normal. And I want to highlight something. Sometimes when we start learning how to contour, some people get confused and draw this as the parotid gland. These are the masticator muscles. So this is not parotid gland. This back here, that's the parotid gland. This here is the tongue. That's totally normal tongue. If I had to guess just from the description here, the tumor bed is right here where Andres is and Leticia are drawing. So the tumor bed was somewhere here. Now, defining the target in this case is very hard. You need to throw everything at it. So let's clear the drawing. And let me see if I can get out of the annotation. Sometimes it doesn't want to cooperate. Here we go. So this is an MRI. Can anybody tell better now where the problem is? See if anybody wants to take a crack of where the abnormality of the recurrence is. Okay, so now the red circle there, that's like kind of the muscles and the mandible. but a lot of people are honing in what I think is the right thing, that enhancement in the MRI. Let's clean the target. When I move my pointer, can you see it? You can see my point. Okay, so I don't need to annotate. Okay, that will be better. So this here, that's the mandible. This black thing here, that's mandible. These are muscles here. But I think everybody agrees that this enhancing area, there's something. That was my contour there. And then I just want to show you the PET. You know, PET is very powerful for squamous cancer. This is an adenoid cystic, not well known for having a lot of enhancement on the PET scan. So there's very faint uptake, but you see that it's not as strong or as obvious as the other cases that we've seen that were squamous cell. But if you can imagine it, there's a little bit of uptake there, kind of correlation. There's some metabolic activity there. Okay, great. Now, another rough case. Let's see if anybody can figure out where the cancer is. So this is a 49-year-old patient, had an salivary duct carcinoma, pleomorphic adenoma of the left lacrimal gland / orbit, androgen receptor positive. And I want to highlight, like, salivary duct cancer, sometimes with the androgen receptors could respond to hormonal therapy. So I know there's more literature on that, but keep that in mind. Some of these tumors, you can test them for androgen receptor, and maybe there's a role for therapy there. Had some progressive visual symptoms, had a left periorbital resection in 98, and had a recurrence. So we were going to do some palliative radiation. So I think everybody very sharply saw the small area of abnormality where it's contoured. Let's clean it. But I want to show you what you could have missed by not doing an MRI in this particular situation. So this is the MRI, and this area here, look at the right side, like the dura, the meninges. Like here, it looks like brighter, thickened on this side. So the contour I drew here is like this. I think everybody agreed with the red one, but that enhancement was suspicious. The orange contour was suspicious for tumor involvement. So if I didn't have an MRI, I would have missed that area. In this case, it's a palliative case. I think with the PTV expansion, we probably would have covered some of that, but you can see that the enhancement is very different from one side and the other in terms of the MRI. Okay, let's go. Let's go to the next scan. How about this case? So this is a right tonsil, P16 positive. He's a patient that I currently have under treatment. He quit after 6 treatments, and 4 years later came back, and he still hasn't metastasized. So we're, retreating him. And I see, a lot of people are in agreement. Let's see what the targets were here. Let's clear it. Let's clear the contours. This is what the PET showed. And these were the lymph nodes in this area. So I put a cut here that doesn't have the primary but has lymph nodes. And you can see the different lymph nodes. There's one underneath the sternocleidomastoid. There's maybe a level 1 lymph node there. There's one in front of the sternocleidomastoid. The other area on the other side, somebody contoured this. That's a submandibular gland on the other side. So these are just the lymph nodes, for this particular case. The patient is undergoing treatment right now. Okay. How about this case?
Hiram,
yeah.
could you speak about with the PET scan, when it lights up in the base of the tongue?
Yeah.
And maybe how you tell, is it like physical exam that from before that there wasn't anything there?
Yeah, so the base of tongue, it's that area that lit up there that somebody circled in orange. That's normal physiologic uptake. from the description of where the tumor was, like, I know there wasn't any base of tongue involvement. You see that it's symmetric. In this case, like, one side looks kind of the same as the other side. So that's normal. Don't jump on it and start drawing it. That's normal activity at the base of tongue. Of course, if you have a base of tongue tumor, oftentimes there will be asymmetry. One side will be larger than the other, but sometimes it's hard to tell where the tumor starts and ends. That's where the CAT scan could help you, perhaps. Maybe, of course, a physical examination could help you with that. Maybe if you want to go fancy, you might want to do an MRI, although often we don't do it. But, that's something to keep in mind. You see that right and left sides are symmetric. They kind of have the same dimensions. That's just normal. There's nothing to worry about there. So, like I said, the PET scan can be very powerful, but you have to learn how to, what to ignore that could be physiologic. You see the chin, there's uptake in the chin. There's nothing going on there. That's just physiologic. Okay, let's go to the next case. So this is a 65-year-old gentleman, squamous cell carcinoma of the supraglottis, and had bilateral selective neck dissections. And, this is a recurrence. This is a patient that was treated and had a recurrence. And I see that there's a lot of agreement in potentially where it might be. This is, this patient had contrast. Patient had IMRT 270 gray. So let's clear the screen. And you kind of see the enhancement of the lymph node. I think it's almost involving, or very close to the skin. I think he had some skin involvement in that area. And then you can see the recurrence there in the larynx. And of course, with the PET, it makes it really obvious. Other areas, might have thrown people off, kind of where my cursor is, just because he had, prior surgery. So maybe the blood supply, etc., is different. So it looks asymmetric, but these were the two spots essentially that were worrisome for cancer. Here's another case. So this is a squamous cell carcinoma of the hypopharynx, right piriform sinus, fixed right vocal cord, had participated in our protocol, received 70 gray. Okay, let's clear the screen. Let's clear the screen and let's see what I drew. So there's like a little lymph node, maybe slightly necrotic lymph node. I think the primary, everybody was kind of in agreement. I think just the muscle, the way it was, like, and the, the zooming, threw some people off, like, this is just normal muscle. You can see here, where the PET lit up, that little lymph node there, perhaps it's necrotic, maybe that's why it didn't light up, but I did see something there that I wanted to include. It's kind of close to the primary, so it makes sense. But, I wanted to illustrate that. How about this case? This case, I don't think I put the history, but let's just say this is a nasopharyngeal tumor.
While they're drawing, we did have one question from the audience from Daniel Ortiz, whether you have a SUV max that you use to include in your GTV targets to make sure that we're including the appropriate amount of disease, not overestimating or underestimating.
Yeah, that's a good question. For the GYN service, they tend to choose certain windows. I just play around with the window myself and try to correlate what I see in the CAT scan, with the PET. Sometimes the PET tends to overestimate a little bit the size of the GTV. And, I haven't set up like a consistent windowing level. I feel like that's more of an art than a science. I know there's the ability to do that. I think our GYN service is a little bit more planned in terms of, what windowing level they use for the PET scan. But I really, honestly, when you're in Eclipse, I try to get rid of the kind of blue background signal. I try to remove it. And then in the end, you'll see that what's really taking uptake is, is what you see in the end. So in this case, everybody seems to be in agreement. I think everybody passed the course, Ben. I think everybody's right in this one. So let's clear it. So that's the MRI, and you can see the enhancement right there, smack where everybody was drawing it. So like I said, in an nasopharyngeal cancer, very useful. Here's what I drew in terms of my GTV. So kind of averaged out with everybody else. And you can see, back here, that's normal brain, that's not tumor, but you see a little uptake in the nose, but you can see the uptake right here in the nasopharynx. If we had an image of this patient before the tumor and after, we would see that this area probably was thinner. Now it's thickened just from the tumor. So everybody did an excellent job here. Okay. So quickly, before we go to the other system to review some cases, I want to show you, I'm not telling you to do this or not do this. I'm just telling you one of the craziest cases that I've had, and the power of the technology, the power of the imaging. And, if I could do it once, I'm sure somebody can figure out how to replicate this, because this is a patient with metastatic cancer that it's been like 3 years now, and the cancer hasn't come back, and I can't explain it. And I just want to share this with you, just to open your minds and think creatively, and push the envelope, because we really can help our patients with the technology we have. So I went to Uganda within the last year, and there's a movie called Who Killed Captain Alex, an $85 budget movie somebody made, and this guy called VJ Emmy, he's narrating the movie, and at some point he said, "Expect the unexpectable," and this is what it is, expect the unexpected. This is a 59-year-old gentleman with a T4 squamous cell carcinoma of the paranasal sinuses, and I didn't know this. I'm not a medical oncologist, but you can do this combined positive score just to see how many cells are staining for PD-L1. And it was 60. So that's high. To give immunotherapy, you just need a score. I don't know if it's of 1 or 2. This guy's tumor was, very immunogenic. And this is what happened. This is the in September of 2020. So just to keep a chronology, this is before the patient went to surgery, and you can see where the tumor is lighting up. You can see the eyes, and they took everything out. I'm not gonna spend too much time in describing all the findings, but they took the eye out. They took everything out. Radical surgery in an attempt to cure the patient. After surgery, the tumor grew this big. I mean, look at this. Before, he had a normal eye. Now where the eye used to be, it's full of cancer. So all this is cancer. I messed it up again with the annotation. Here we go. So that's my GTV. And here is the PET scan representing that. So you can see the tumor, and the patient had like 2 or 3 lung metastases. So oligometastatic patient, huge tumor, surgery didn't work. So everybody's panicking. And that's kind of what I described quickly. Can you give me a second? So I'm getting a call quickly here. Hello?
Sure. And we've had really good questions in the chat, so feel free to keep adding your questions. We'll see if we can go over them if there's time.
Everybody started panicking and started the patient on chemotherapy. to buy the patient time before, I try to do something with radiation. The tumor grew through the chemotherapy. So surgery, fail. Chemotherapy, fail. Nothing is working. The guy is like, what are we going to do? So in this case, I did a definitive course, 70, 56, but I did something unusual. I gave a boost of 10 gray. Those of you who are in H&N in Peru, you've sometimes done like a palliative 10 gray courses. I've used boost of 10 gray sometimes in desperate situations. So I spoke with the patient. I said, this is not standard. This is something, we don't routinely do, but it's a desperate situation. The tumor is growing so rapidly, we can't control it. Surgery didn't work, chemo didn't work. It's gonna cause a lot of problems. How do we control it? So I did a 10 gray boost plus this. This is the patient simulation, with the mask and everything. This is my GTV, like I said. And this is kind of the schedule. So I did the boost, maybe after a week of 2 gray perfraction treatment. So I'm going to go quickly so we can move to other things. But what you see here is this, the 10 gray boost is right in the middle of the tumor, kind of this area here, and then it falls off. So the edges of the tumor are getting just 2 gray. Okay, so my normal toxicity is not going to be enhanced in any significant way, because by the time I get to the edge, it's like 2 gray perfraction. So my normal tissues at the end of the day, they just saw 72 gray. The normal tissues saw 72 gray. The center of the tumor saw the equivalent of probably 100 gray. Okay, but it's tumor. There's nothing vital there. I mean, that's where the eye used to be, that it's gone. There's no nerves there. It's just tumor. If the patient went and had a second surgery, they would have taken all that out and throw it in the garbage. So there's nothing useful there except killing the cancer. So that's what I'm doing there with the 10 gray. And this is what happened. So you can see my GTV, you can see you can see my PTV 7000, my PTV 5600, my PTV in green for the 10 gray boost. I couldn't achieve 10 gray all the way to the edge, but at least in part of it, 10 gray, and then it drops off. It's like some areas got 9 gray, 8 gray, 7 gray, 6 gray, etc. And this is a plan. And I'm just going to fast forward. You'll have access to the presentation. You can digest it at your own leisure. I did SBRT for these 3 long lesions. So I did 10 gray times 5 to each of the long lesions. And this is the simulation, for the long SBRT. You can see that the patient is very cachectic. He has an eye patch because he just lost the eye from the surgery. And you can see how I scheduled the long SBRT. So April 2021, okay, so this is more than 3 years ago, he completed radiation. Okay, this is the radiation SBRT to the lungs. So along with our theme of the GTV, these are the areas that we treated. And then he continued on immunotherapy till, I think today, till today, he's still on immunotherapy. And this is what happened. So July of 2022, tumor is gone. Chemo didn't do it. Surgery didn't do it. Radiation did it, plus minus the immunotherapy. The tumor is gone. The lesions in the lung are gone. So I've done this set of slides periodically, and I keep updating it. So the MRI, no evidence of local recurrent or distant metastatic disease. This is August of last year. Same story. Hasn't come back.
What was the histology?
Squamous. So it's a squamous, but like I said, it was like a very immunogenic type of tumor, it looks like. 1 year later, hasn't come back. Last night, when I was preparing the slides at 1 in the morning, I looked at the patient, I found his name, and I'm like, let's see what's going on. So in April of this year, he had another scan. It's still the same. So I just want to show you, like, with the technology, if you have, I mean, I'm not telling anybody here to do what I did in this situation. I think in the ideal world, we should do like clinical trials, etc. This was a desperate situation. The patient understood the risks. In this particular case, it worked, and we were able to do it safely. The patient lost tissue there, at the palate, etc. But he's still alive. 3 years later, these types of events, this shows that it can happen. I don't know how to do it consistently. This was like a one-off. I think the interesting thing is like other modalities didn't work, and maybe between the immunotherapy and the radiation, that's kind of where the balance was. I can't explain it, but I think as you mature in your planning, in your head and neck expertise, you may feel more comfortable doing more aggressive treatments, and truly using the full potential of the technology in the patient's benefit. Okay, so I think I am done. This is the last report, from April. There's some nodularity that's stable and indeterminate, so we're going to be monitoring that. But that's the end. That's my email. And I just want to pause and have maybe ask people if they want to ask questions or anything that didn't make sense, or things that made sense. If there's any comments, I think that would be a good time to take a breather and have a discussion.
Great. And Hiram, maybe while we're getting to those, if you want to pull open Prono,
Yeah,
there's
so
that
let me,
there's one case that I think is really relevant to the case you just shared. I think you'll like it.
yeah, I think I got it. Which one did you want me to open?
So this is Cavum.
Cavum.
And so this was one of the cases that was submitted by a participant. So thank you for sending this case. And if you click the notes on the right side, and
If I click on the what?
right here where it says notes.
It says, okay.
So this patient was treated in 3 phases. The first was a 30 and 5 to the center of the tumor. Kind of like how you were just describing, you did a boost into the middle. And then they went on to receive 44 and 22, and then adaptive treatment with an additional 30 and 10. And this is the plan that you can scroll up and down to kind of see what it looks like.
Yeah, let me zoom it in so it's larger. Okay, and what contours can I turn on here?
Yeah, so if you click, well, so first we'll just look at the dose. And
okay, so this is what, 81 gray? Is that what this one means? Okay.
And this area here in the middle is what they boosted to 30 gray and 5, the center of the tumor. And so we have a sense of the dose that was planned. Let's focus on the contouring now, since that's the focus of this. So turn off the dose by clicking this little eyeball. Great. And now click structures here.
Okay.
Great. And so red is the CTV 60, this one right here. And if you want to be able to edit the contours, click this edit structure set button in the top right.
Okay.
Great. And now you have your little contouring toolbar on the top, pencil or brush here, and feel free to scroll, and we're interested in your expert thoughts.
And is there any additional data set or no?
There is a MRI.
Okay. How do we switch between one and the other?
Click, let's see, you may need to click delete draft first in the top right here.
Oh, delete draft. Okay.
Yeah, and then click OK, delete. Yeah, and now go back to browse. And now here, MRI, that's selected. So here on the right, images is where you can adjust the fusion on the far right here.
In the far right, okay.
Great. And now you see the scale bar. So drag this, and this is the opacity.
Oh, I see. So, it's hard, sometimes, without knowing all the details, it's a little tricky, but I would say, let me go back and forth with the opacity. To me, I probably would cover either electively or, make a little bit larger my GTV, or at least, cover electively with those the sinuses, because sometimes with the opacification, it's really hard to tell where the tumor starts and where it ends. The tumor may have gone a little bit more superior. So all this to me, could be at risk. And, if we look here at the eye, it seems to me that there might be, can you see my arrow, right? I don't know if there's tumor encroaching here in this area. It could just be normal opacification, like fluid, not fluid, but like, mucus, etc., impacted there that cannot drain. But, even as we go down here, I wonder whether there's some tumor to the right of the GTV here. Electively, cases like this, where they could have eroded or gone through the contralateral sinus, sometimes I cover electively the contralateral sinus. Here, if you see the contour, it's jumping back and forth. So if you look at the posterior border, already, to me, it's like a little bit of a red flag, in the sense that, let me see if I can move the cursor here. Okay, so look at the sagittal view. See that the contour is like, like an EKG going back and forth. Tumors usually won't move from one slice and jump quickly and be narrow and then get big again. So this is something that, for example, here, this probably is tumor, that this contour should go more posteriorly. If you had tumor up here, and if I had to guess, it's going, back here. Let's see what the MRI shows. But I would think, maybe it's going posteriorly here, but here, we could have missed all this, in terms of the GTV. Here, we could have missed this posteriorly here. So, when you're reviewing a case, I know I'm off a little bit if I see a lot of jumping around for the contour. When you scroll back and forth and you see it wobbling a lot, it's maybe you need to reconsider and take more time as you draw and see what happened. Why did it jump from here to here? Either I drew this too big down back here, or I did it too small of my contour there. So those are, important things to consider. Physical examination important here. Is it going down to the, superior alveolar ridge there, to the lips or not? Is there an induration of the lip? But especially posterior, I think that might be what I would be more concerned in this particular case. Let's see if there's a elective volume.
I think this one may have been reirradiation for a recurrence, so
There might be okay.
Yeah, they may not have chosen
So
to
Ben,
do big
were there
electives.
any comments and any feedback from this case and what happened to the patient?
I think the patient is alive and doing okay.
Okay.
But
So
wouldn't say it's
these
a
are
happy
these
ending.
are some yeah, like here, what's happening next to the eye, I would be concerned. And is there any tumor going a little bit more towards the frontal sinus? That's where all the different image modalities, etc., PET, MRI, would be helpful. I'm trying to think, when you combine hypofractionation and standard fractionation, be careful. The only thing I didn't like about this one, I think it's okay, but you don't want to mix 3 gray per fraction, 6 gray per fractions, 2 gray per fraction. Don't overcomplicate it, because the problem is when you try to evaluate that DVH, unless you have maybe Monaco or one of the planning softwares, you can do like a radiobiological equivalent, like you want to get the EQD2 dose, for the plant, like the equivalent dose in 2 gray. But when you're looking at 3 gray, 10 gray, what does 80 gray mean? Is that 80 gray 100 gray in 2 gray, or is that dose the equivalent of 40 gray, or what am I looking at? So in the approach I did to simplify that concept, I just said, I told my, Tom Masser, who's like our expert planning these, and it took us a number of cases for him to feel comfortable with how strategically what I was looking at. But I'm just saying, hey, at the edge of this boost, I'm giving 2 gray per fraction. So when I review my DVH at the normal tissues, I know the worst case scenario is going to be 72 gray or something like that. Where I have this crazy boost, it's just tumor. And you have to look at the anatomy. It gets dicey with the lymph nodes, because you want to make sure you're not treating the carotid. You don't want to boost something in the middle and then their carotid is right or smack in the middle of the tumor. So you have to be very judicious looking at your anatomy. Is there a blood vessel there? But in my patient, it was really a simple decision. It was a sinus. The sinus doesn't have anything to begin with. They took the eye out. So we have a patient who had a cavity that got filled with tumor. So I know all of that is tumor. I can do whatever I want to it. The surgeon would have taken it out anyway, and it's okay. I have a way more complicated case, but it's palliative with a skin cancer. And that I applied some of these principles, maybe for another time. Did you want to show another case? I know we're running out of time. I'm more than happy to stay as long as anybody wants, but I want to be respectful of others' times. So, I'll just go along till, the Zoom ends.
Thank you, Hiram. Michael, I think, saw some good questions in the chat.
Okay, so somebody asked, let me go from the bottom up. So lattice, we do lattice. We have a protocol here with lattice. It's okay, we're doing it as part of research, but for this, my approach to what would be the equivalent of lattice is, instead of having many little balls, I just have to have one big ball in the middle. I'm like simple lattice, okay? And you saw that it worked in this patient. So I just go to give as much of that central core of the volume, hopefully that hypoxic core of the volume, that big boost. Lattice is fine. The other day I went to the machine to cover a lattice case for one of my colleagues. I think it's promising, but if I can treat a larger portion of the tumor in a simpler way, why not? That's all I have to say. I think if the tumor is gigantic, we'll see what the data shows. But yeah, let me see.
The question about bolus and your thoughts about when to use bolus.
For bolus, we don't tend to use it as much unless it's really the tumor is at the surface of the skin. With IMRT, if you put the skin dose is higher, so it's usually enough to give a decent dose underneath the skin if it's not like gross tumor at the surface. This patient that I was mentioning had like a cauliflower chunk of tumor growing on the skin surface. So yeah, we put bolus in that case. But with IMRT, even if you shave the skin instead of 3 millimeters, 2 millimeters, it'll heat up. You'll get a decent dose to the skin surface. So even when we're treating a risk risk area near a stoma or something like that, we might not necessarily use the bolus consistently, just because with IMRT we tend to heat it up. If you're really worried, go ahead and do it. Let's see. Okay, how many centimeters to maintain safety? So in this case, I don't know if I would say at least carving the tumor 0.5 centimeter or 1 centimeter, depending on how big the tumor is. You'll see it. I would say give yourself at least 0.5 centimeter distance. You're just trying to do a boost. The physicists, if they're very sharp, the 10 gray will be just very central. It's just going to be a gradient. So there's two ways of, let me see if I can annotate. There's two concepts of how to do this high dose in the middle. So if we look at a cross section of the dose, you could say, hey, you could have two different approaches. So let's say the top part is 10 gray. So if I look at a cross section of the patient, it's like, it kind of, there's a gradient, and then you get 10 gray and then go like that. Or you could try to keep it very hot, and you could do something like this. Like make it, just for out of exaggeration, put the top 20 gray and go like this. Okay. What do I like to do with my physicist? This approach over here. Why? Because I'm giving that 10 gray to as big of a volume as I can. When you give radiation, that energy, there's only so much you can start giving until it starts spilling out to the normal tissues. So I'm less interested in giving a super high dose to a small volume. I'm more interested in maximizing the volume that I'm giving that 10 gray as much as possible. So the larger that 10 gray can be, the better. I feel like if I'm wasting and trying to do like a super hot spot in the middle, I'm wasting some of that fluence and just treating a small portion to the dose that I want to give. Okay, do I recommend working with a nuclear medicine doctor? I mean, if you have that ability, sure. I think all I can point you out at WashU is the cervical PET scan experience with Dr. Perry Grigsby. You can see some of the papers they did and how they looked at, he worked a lot with nuclear medicine. So he did a lot of research with the metabolic tumor volume, how they defined the windowing level and all that. So, I would suggest looking at Perry Grigsby. I'm gonna put it in the chat. And he was like, he did a lot of PET CT for cervical cancer. So Diana asked, I try to keep it more uniform, more a plateau, rather than like some hill like in the 20 gray. Let's see, the most important thing is that the PET scan helps draw your attention. Oh, that's what you wrote, Ben. Okay, Ben put a comment.
I hope that sounds good.
How can we differentiate the physiological uptakes in the PET scan? That's where the physical exam comes in. That's where looking at the patient comes in. That's where, you're not going to have a windowing level that's going to help you, because it's going to be very bright. That tonsillar lymphoid tissue, it's very, very bright. And actually, a PET scan, I almost made a mistake once in my career, and I'm embarrassed to say this, but I'll share this with you. So I had a patient, it was the holidays, rushing to get everything done before the holidays come in. And I had a patient with a base of tongue tumor. Now, I right away drew let's say the right base of tongue. The left base of tongue looked clean. and I just drew the left one didn't have any uptake. So I said, okay, this is it's not lighting up on this side. It's lighting up on this side. Okay, this is where the tumor is. Wrong. I made a mistake. The patient, I forgot that the patient had had surgery. So where it didn't light up, they had taken the tumor out, so it wasn't gonna light up. What I drew was the normal tonsil on the other side. So fortunately, we picked that up, like, it threw me off. I instinctively saw it light up. Okay, I'm drawing it, but the side that wasn't lighting up, they had taken it out from the surgery. So I could have made a mistake. So that's why the PET scan, when you start contouring using PET scans, hang out with your nuclear medicine doctor. When I started my career, I would go to the nuclear medicine doctor all the time to learn, what's normal, what's not normal, because it's hard at first. And it can be even more dangerous, drawing things that you shouldn't be treating and giving the patient more toxicity. So go to your nuclear medicine doctor, knock on their door, ask them what they think they see or not see. And, hopefully, if they're very experienced, they can help you quite a bit with your contouring. Let's see, organs that, yeah, go ahead.
I'm so sorry to interrupt.
Yeah.
We are at the hour and a half, and thank you so much to our interpreters for staying on just a little bit longer. I think we will conclude the session now. This has really been excellent. I want to highlight one comment from Dr. Marta Isabel Cotes in Colombia. So that's, really nice to see. We're so thankful for you, Hiram, for everything you prepared today. Michael, thank you also, and welcome to the RCC team for first time moderating. And with that, any final words you want to say, Hiram?
No, I mean, I put my email. I send you like the slides. If there's any reference you need, you have my email. Any way we can help you. I think head and neck is challenging. I think it's, if we do it right, we can help the patients, tremendously compared to other cancers that we treat. I know around Latin America, from the times I've visited different centers, people are doing very unique, and they're pushing the envelope with 10 gray boost or 3, or this case that was so interesting. So I think we have to remind ourselves, maybe it's time to do some protocols, some collaborations. So maybe we can standardize this and learn from each other, because I think there's value. I saw it in Peru when I visited there, like some amazing abscopal effects in some patients, or tumors that were gigantic and patients couldn't eat and they can eat. So each site has their own approach. I showed you like a hybrid approach. I've seen other types of approaches. So it's not just what's in the US. You have the power, you have the knowledge, and you're trying to help the patients the best you can. So keep pushing the envelope and keep fighting the good fight.